My name is Francesco Sanvito. I'm a resident in Pavia University. This study was performed at Mondino Hospital. So just want to point out the results of this study has been recently published, so you may refer to the actual full paper if the presentation is not thorough. So first of all, the speaker before me introduced the technique already a little bit. ASL is a very interesting perfusion imaging technique where we don't even need contrast agent administration. We just can magnetically label protons in the arteries in the neck and then acquire the image of the brain with and without the labeling, and by subtraction we can get a perfusion-weighted image that you can see in grayscale. After that, there's some quantitation and calibration steps that you can do in order to get an actual CBF map. There's multiple ways to perform the labeling, but long story short, we get these very nice perfusion-weighted images or CBF quantitative images, and specifically in our case, in our experience, we use those in epilepsy children because some seizure-induced alteration may affect perfusion in terms of hyperperfusion, like in case 1, or hypoperfusion, like in case 2 and 3. So what is this inversion time that is the main focus of the talk today? As the speaker before me was introducing, we need to wait a certain time between the labeling of the blood and the readout of the brain. Then that is required because the blood needs to travel all the way to the tissue, right? The theoretical time that is required for the blood to travel is called ATT, anterior transit time. So that's why we have to wait a certain amount of time. So picking a correct TI or PLD, depending on the technique, it's called differently. It's kind of challenging and it's type of compromise, because if you pick it too short, you are not imaging brain tissue, you're imaging perfusion in the arteries. If you wait too long, there's going to be a signal decay, you lose the labeling that you did, and you get lower SNR. Right now, the recommended TI is 1500 milliseconds for children, and we had a curiosity of seeing what happens if we extend it. The curiosity comes from the fact that we had a previous protocol that had 2000 milliseconds, so we were curious what is the difference if we change it to 1500 in order to comply with the guidelines. So we imaged 12 kids, mainly with epilepsy. It's MRI negative kids, so it's normal brains morphologically. And we imaged them both at TI 1500 and TI 2000. You can see like 1500 in red, 2000 in blue. We performed both a volume of interest type of analysis, say, let's compare one TI with another in gray matter or basal ganglia, frontal cortex, and whatnot. And also a voxel-wide analysis where you register the two brains, and voxel by voxel you see the difference with the two different TIs. And also perform a Z-score on both analyses to see what the relative difference within the individual would be. So first of all, you can see the VOI analysis on the left and the voxel-wise analysis on the right. It's easier to see the voxel-wise analysis for now, where we see red voxels and yellow voxels are the ones where perfusion would be higher with a shorter TI, and the blue ones would be the ones where the perfusion is higher with a longer TI. You can see that what we call the proximal territories and the arterial territories would be higher at TI 1500. That means it's arteries, and it's the tissue that is very adjacent to the arteries. You can see the insula, part of the perisylvian cortex. If we wait longer and we use a longer TI, so 2000, we get higher signal in the distal territories, including all the watersheds between middle cerebral artery and anterior cerebral artery, and also posterior cerebral artery. And similar results we get by computing Z-scores on gray matter, both again on VOI analysis and on voxel-wise analysis. This is just a 3D rendering of the Z-scores, so you can clearly see, like in a 3D type of fashion, how all the perisylvian territories would have higher perfusion with a shorter TI. You see like perisylvian cortex, insula, anterior cerebral artery, and middle cerebral artery, whereas all the posterior circulation, the watersheds and the distal territories are all blue, meaning it's higher perfusion with a higher TI. We were curious, like, is it just something that we see from a group analysis, or we also like pops up from a single subject evaluation? And yeah, like it's pretty apparent on the single subject too. We pulled one subject, for instance, for this presentation. You can see that At a shorter TI, you get the lower occipitotemporal areas that are low perfusion, and the same subject, if you wait for a longer TI, that area has become regularly perfused compared to the rest of the cortex, to the extent that that area in the watersheds looks like white matter in terms of perfusion signal. So the watersheds look hypoperfused with a lower TI. So the fact that watersheds may look underperfused with a lower TI is no news, because we know that ATT, so the time that the blood needs to travel to the distal territories, is longer than the proximal territories. What is curious is that the recommended TI would be 1500, so the shorter one that we used. So our impression is that if we use a short TI, that is the recommended one, we may underestimate the CBF in the distal territories because blood hasn't gotten there yet, and we can overestimate the CBF in the proximal territories because we are imaging blood in the vessels pretty much. So maybe our impression is that TI, the longer TI for the children too, 2000, would be actually more accurate. And this actually has some clinical implications, because you see on the right, there's a hyperperfused area, and it could be a real hyperperfused area due to a seizure, or it could be because the TI is too short. You don't know. One thing you could do is just image again with a higher T1 and see if that changes. And the other example has nothing to do with my talk, but I reviewed the literature about this. There's a border zone sign that was mentioned before that is important for the Alzheimer's disease. And it has been reported that ASL gives false positive results. But if you look into the methods of those articles, many times they use a very low TI or PLD. So we're wondering, probably they just didn't let enough time for the blood to get there. With this study, we don't have possibility of saying recommendations and telling what the ideal PLD or TI would be. We need more multi-model imaging, other perfusion studies, or multi-TI ASL to figure that out. What we can say is that we have to be aware of this limitation of ASL, and when we see this type of hyperperfusion, we always have to look into our sequence parameters, see if the TI was appropriate or not. When in doubt, you can also call back the patients and reperform that with a longer TI if you're in doubt. With that, I'm done with my talk. Thanks for listening. I wanted to thank all of the crew in Pavia that helped me out, specifically Professor Picchiacchio that was supervising us. Thank you.